Hello everyone, welcome to the second lecture of the series. So today we'll be looking into the mental status examination. So in the last video we have looked into the neurocognitive function or the higher mental functions. In this video, this is the second video, and we'll be looking into the mental status examination. So mental status examination actually gives an overview regarding a patient, be it inpatient or outpatient. So first of all, let's look into the heading of mental status examination. So if you look into the heading, the headings can be general appearance and behavior, the psychomotor activity, eye-to-eye contact, rapport, speech, mood, disorder of thought, and disorder of perception. So in this video, we'll be discussing each and every heading of mental status examination. First of all, let's begin with the general appearance and behavior. So in general appearance and behavior, what you have to describe is how the patient entered the interview room. So how the patient, number one is the entry in the interview room. Second, whether he wished the examiner or not. Third, describe how he sat in the interview room. Whether the seat was taken by himself or was being offered by the interviewer. How the patient was dressed. Do describe about it. His grooming and the cam. So describe regarding the dressing, how the patient was dressed, whether the condition of the dressing was out of proportion to the interview setting, whether it was poorly dressed, ill-groomed. So we have to describe regarding how the patient was dressed. After that, do mention regarding the looks of the patient. Mention regarding the awareness of the surrounding, whether the patient was aware of the surroundings or not. Also mention regarding any abnormal movements, like for example, any sort of tremors, any sort of foot tapping. Do mention regarding that. Also mention regarding the hallucinatory behavior. Whether hallucinatory behavior was observed or not. Do mention how the patient was answering to the questions that were asked. That is, answering to the questions. Whether he was giving detailed explanation, whether he was evasive or was avoiding the questions or was changing the topic, whether he has answered the questions in accordance to what has been asked, or was like how the patient do. Like most of the times, if a patient is having circumstantiality or tangentiality, they might begin with the topic that has been asked, but definitely will be getting deviated during the course of answering. So do mention whether the answering by the patient was according to that of the questions, whether he was giving proper details or not. So you have to mention this in the general appearance and behavior. In this only, do mention the any compulsions. Okay, so in general appearance and behavior, these are the various things that has to be mentioned. Again, I'm making this video very slow because this is particularly directed for the first year. So take it gradually, learn how to write the general appearance and behavior. Okay, so usually general appearance and behavior, it starts by that a person of stated age entered the interview room. He wished the examiner, sat on the offered chair. The patient was moderately groomed and kempt, was wearing, for example, a shirt and a pant, was looking into the uh, to the interviewer. He was aware of his surrounding. No abnormal movement or hallucinatory behavior was observed. You can also write whether any abnormal movement in form of tremors, in form of chorea, in form of atetosis was observed, or if hallucinatory behavior was observed, do describe it in your words. And I also mentioned that whether the individual was answering to the questions or not. If any compulsions were noted or compulsive behavior were noted, do mention it in this general appearance and behavior only. At the conclusion, do write regarding the overall attitude of the patient. That is, whether the patient was cooperative to the interviewer or not. So overall, the patient was cooperative or not cooperative to the interviewer. Once we have done with the general appearance and behavior, so this part is over. We will be coming into the psychomotor activity and eye-to-eye contact. Okay. So after general appearance and behavior, we'll be looking into the eye-to-eye, the psychomotor activity. First of all, we should be knowing what is psychomotor activity. So in general, one can understand just by merely looking at this word, that psychomotor activity. So psychomotor activity is the motor component of the psychic activity, which is evident through speech and behavior. So it is having three core components. That is motor component of, this is the number one, psychic activity, evident through speech and behavior. So this forms the three core component. So psychomotor activity, it is actually being defined by relating to the combined physical and the mental activity. That is, both part is being included. So it includes both the physical plus mental activity. So accordingly, one can rate whether the psychomotor activity was increased or decreased. So for example, in depression, it is reduced. In mania, it is increased. In schizophrenia, if the patient is aggressive, you can write it as increased, or whether the patient was having reduced psychomotor activity according to the judgment of the interviewer based upon the patient's action and regarding the thought component that is ongoing. One can rate whether the psychomotor activity was increased or reduced. This also comes by experience. You keep on doing the mental status examination, and gradually these things will become very much easy. So next in the line is the eye to eye contact. So eye to eye contact. Eye to eye contact is very important to mention because and it is one of the key components of psychomotor of the mental status examination, and you can write whether the eye contact was made or not. So first is whether it was made or not made. That is whether the eye to eye contact was made between the interviewer and the patient or not. So this is the first component, that the that the eye to eye contact was made or not made. The second part which comes after this is, if made, whether it was sustained or ill sustained. This is the second component. So while describing eye to eye contact, you have to first mention whether the eye to eye contact was made or not. So if made, whether it was sustained or ill sustained. Okay. Next in line comes a very important heading, that is rapport. Let's write the definition of rapport. This is very important. You have to jot it down like this. You have to remember it like this only. So what is rapport according to CTP 10th edition? By the way, this core component or the three core component was also according to the CTP 10th edition. So the definition of rapport is spontaneous, conscious feeling of harmonious accord, sympathy, and mutual responsiveness. So it is a spontaneous, conscious feeling of harmonious accord, sympathy, and mutual responsiveness that promotes the development of a constructive therapeutic relationship. Each and every word in this definition is important, and you have to remember it like this only. There is no excuse whether uh, it is difficult or not. So that is the reason why I keep on doing, like, I always try to break the definition into number of core components that are the key factors and the important components of the definition. It helps in making the definition easy, and these components shouldn't be missed whenever someone asks you regarding the definition of rapport, or be it any heading. That's why you have observed me that whenever I am discussing any definition, I break it into number of important components that you have to, that is a must whenever you are answering regarding that topic. So in this also, it is a spontaneous, conscious feeling of harmonious accords, sympathy, mutual responsiveness that promotes the development of a constructive therapeutic relationship. So this completes the definition of rapport. Sometimes a question is also asked regarding the what are the various components of rapport. So let's look into the components of RAPO. So first of all, if we look into the total number, there are 7 components. So first is the perspective, lines, comfort, expertise, trust, insight, and last is the guidance. So these are the 7 components of RAPO. You also have to remember it. So how to report RAPO? So whether you can mention whether RAPO was established or not. So you can say that RAPO established, RAPO not established. If the patient is amenable for interview, however, the details of the thought process or the various questions which were being asked was not answered, that means the RAPO is in development of the, like it is in the phase of development. So you can say that the RAPO has been is in the process of development, however it has not been established. In that condition, you can use the term of therapeutic relationship has been established, however RAPO has not been established. So therapeutic relationship has been established. You can name it when the RAPO has not been established, however the patient is available for interview and he is opening up to you. Fine. So we have covered the general appearance and behavior, the psychomotor activity, eye-to-eye contact, RAPO. Next in line is speech. So let's discuss regarding speech. So if you look into speech, so there are a number of components of speech that we have to look into, and speech also has been described under these headings also. So first is whether the speech was coherent or not. Coherent, the meaning of coherent is whether the speech was logical, consistent, understandable, or not. So if the speech was logical, consistent, understandable, then we can label the speech as coherent. Whether the speech was relevant or not. Relevant means whether the speech was in accordance to the question. So it might happen that number of times if you ask a question, the patient might not reply back in to the same topic to which the question has been asked. Rather, they will say something else. For example, in circumstantiality or in tangentiality, the patient deviates from the topic. However, if he or she keeps on describing the topic that he has been describing, if you are able to understand it, if there is a logical sequence in this and the speech is understandable, you can label it as coherent. However, you can say that it was not relevant because it was not answered in accordance to the question that was being asked. So relevancy means whether the answer has been done according to the question. Coherent means whether the speech was logical, was consistent, and was understandable or not. So these two terms are very important. We have to differentiate it. So keep in mind regarding what is coherent, what is relevant. Next is the tone. You can label it as the tone was raised or tone was low, and it actually means loudness. Next, you can say the rate. So it is the speed of speech, or in some books has been mentioned as the tempo of speech. Then volume. So many a times people do get confused what volume has been, like what is volume as far as speech is concerned. It's not regarding the loudness or the that has been mentioned by the tone. Okay, so volume means whether the amount of speech, it denotes the amount of speech. Sometimes the patient answer a lot in response to a question, and the patient keeps on answering, keeps on giving responses, and it becomes really difficult for the interviewer to stop. In that case, you can say that the volume was increased. Sometimes the patient was will be giving a very limited answer, will be only answering in a in a single line or two, or may answer in a single word also. That times you can say that the volume is reduced. So it actually means the amount of speech. Loudness has been taken care by tone. So you can say that the speech was relevant, coherent, the tone, the rate, tone, volume was within normal limits, or you can accordingly say how the rate was, how the tone was, how the volume was. Then you have to describe regarding the reaction time, whether the reaction time was increased or reduced. So in response to a question, whether the individual takes some time to answer, or whether the individual instantaneously, even before the completion of the questions, spurts out the answer. That's how the reaction time has been assessed. So definitely you can say whether the reaction time was increased in case the patient takes a number of, like, you have asked the question, the patient is answering it after 4 seconds, 10 seconds, maybe a minute later. That time the reaction time has been increased. Or in case of mania, the moment it you have started asking a question, only if the patient starts in between the question, he starts answering in between the question, that time the reaction time is reduced. So increased reaction time is seen in, for example, in case of depression, where the patient takes more amount of time to start answering, and reduced in case of mania. So if you look as far as speech, so these are the various headings under which the speech has been described. Next comes mood, very important. Some of the institutes also mentions intonation, so you can write that also, intonation, whether there was fluctuation while answering or not. That is while answering, whether there was fluctuation in the note of speech or not. So these are the intonations. Let's look into the mood. So while describing mood, first you should understand what is mood and what is affect. So while defining mood, again, there are some of the key pointers or the core components of the definition, that it is a pervasive, it is actually a pervasive, sustained feeling tone. So it is a pervasive, sustained feeling tone that is experienced internally. So it has been experienced internally, and it influences all aspects of person's behavior and perception. So this is the complete definition. That is, it is a pervasive, sustained feeling tone that is being experienced internally, and it influences all the aspects of person's behavior and perception. CTP ventilation. What about the affect? So affect is actually a cross-sectional examination of the mood. It like, for example, in the definition of mood, it has been said that it is a pervasive. Pervasive means it and sustained. So these two terms are important. So mood, by these two terms only, it becomes a longitudinal measurement, and affect becomes cross-sectional. Affect, it is the emotional state which is judged by external reaction. So this completes the definition of affect. So these are the two important components, that is the emotion state judged by external reaction, and one more last component, it is transitory in nature. So let's look into the various headings of mood, how you describe the mood. So mood firstly has to be described whether how it is on the basis of the subjective and the objective mood. So in subjective, you can ask the patient, how is he feeling or he or she feeling? So always write subjective based on the uh, how the patient is feeling at the moment of interview. Objective is interviewer's observation. So subjective and objective, you have to write it like that. Then you can say whether the mood was appropriate, appropriate and congruent. So appropriate means with respect to the situation, and congruency means with respect to the thought process. So these are the important headings in which the mood should be described, whether how the patient is feeling, how the interviewer's observation, what is the mood, whether the mood was appropriate, whether the mood is congruent. Next, in this heading, as we have come through, so we have discussed general appearance and behavior, the psychomotor activity, eye-to-eye contact, rapport, speech, mood. Let's come to the disorder of thought and disorder of perception. These are the last two headings. So first is the disorder of thought. So in this, various subheadings are form, flow, content, and possession. So accordingly, one can put various formal thought disorder, various type of psychopathology in these four headings. So what happens is like most of us, they like in various institute, they follow different things. But what I am deciding, or what I have been taught, how to label psychopathology under these four headings, it depends how it has been described in Fish. So that's the very standard textbook in which we can describe various psychopathology of disorder of thought under these four headings. So for example, if there is flow is concerned, so let's discuss about flow. If we have to write under flow, what we can describe. So under the disorder of thought flow, one can describe inhibition or slowing of speed, that is thought block. One can also discuss regarding the raised speed, flight of ideas. And disorder of thought continuity, in which thought block and perseveration is there. We can also discuss this here all. Perseveration. So as has been given in Fish, we'll be labeling it accordingly. So in form, all the formal thought disorders. In content, we can write regarding delusions, overvalued ideas, preoccupation. In possession, we can write regarding obsessions, or alienation. So whenever we are describing disorder of thought, as has been given in Fish, we can label various psychopathology under these four headings. So the very important thing while eliciting the disorder of thought is to ask an open-ended question. Like for example, ask the patient how we make tea, or how we board a ticket for a bus ticket. So how do you like we can also ask regarding how one celebrates Diwali, Holi, Eid, Christmas, whatever be there in the cultural aspects or the background of the patient, one can ask an open-ended question. So if, for example, if I ask the patient how we make tea, the patient might start by saying that firstly we have to take water, milk, sugar, tea, and then we start boiling the water, then we place the milk, accordingly we place the tea also, then the sugar. But on the process of answering, he might deviate from the topic, or might give some explanation, might add on some words to it. So it becomes an open-ended question in which the patient has to describe. Close-ended question only comes into rescue when the when the rapport has not been formed or the patient is unnecessarily evasive, the patient is deviating too much, then at that moment, closed-ended question is there. However, if the rapport has been developed and the patient is comfortable in the interview, open-ended question is the first thing that we should be trying whenever we have to elicit the disorder of thought. While asking the open-ended question only, these components of speech that we have just talked, these will be elicited. So open-ended question serves number of purpose. First, it will be helpful in deciding the disorder of thought. Various headings will be decided by open-ended questions, that is while giving the speech sample. Also, the various components of speech will be decided by that only. As far as the mood is concerned, according to the description or according to the specific questions that are being asked, we can also label whether the mood was appropriate or congruent. For example, the patient is laughing and is feeling happy at the death of an individual. So that is mood incongruent or inappropriate to the situation. So we have to look into while labeling appropriateness and congruency as far as mood is concerned, and that can be asked through open-ended question only. So open-ended question is it forms the very important component of mental status examination, because the whole thought process or the internal component, the psyche activity of the patient becomes evident through it. The last in this MSc is disorder of possession, in which we mention regarding the hallucinations. Visual hallucination, auditory hallucination, any type of hallucination is being mentioned under the disorder of, sorry, it is perception, not possession. So these are the various headings under which the mental status examination has been described. Most of the headings which I have taken is from, sorry, Mayer and Gross. Some institute would like to add on some various other headings under various subheadings of mental status examination. It is according to college, so you can definitely add it. The purpose of this video was to make it in a very structured manner, that these are the various headings in which mental status examination has to be described, and these are the headings which you can't miss. And we should be knowing regarding the definition of each and every headings of mental status examination, which I have described. Various components of rapport, what is mood, what is affect, all has been described. What are the various headings under which mood has been described, has to be described. Speech, how it is being described, how to label the disorder of thought. So always follow the classification that has been given by Fish, that as far as form of thought is concerned, what to include. As far as the content of thought is concerned, delusion, overvalued ideas, preoccupation, all comes under it. In possession, obsession, thought alienation phenomenon, all comes under it. That is the thought broadcast, thought withdrawal, everything comes under thought alienation, and this becomes a disorder of thought under possession. Similarly, for the flow also, inhibition or slowing of speed, thought block, perseveration, flight of ideas, all should be described under flow. And open-ended question helps a lot as far as describing the disorder of thought, speech, and mood is concerned. Same goes for the disorder of perception, in which hallucinatory behavior, which we previously mentioned in the general appearance and behavior, now you have to give a description to it. Okay, some important thing, whenever you are describing, do write the speech sample. Speech sample should be in accordance to that of the patient's word. Also, one can write in the native language as far as the patient, if you know the language, if you are comfortable in that, or you can make a English or a English translation of that. You can explain it to the examiner. It's better to go in accordance to the how the patient has described it. So try to write in the patient's word only. Do write the questions that you have asked. Many a times we are able to say the speech sample, but we do forget to ask the to tell the examiner regarding what questions we have asked. So always write the questions that we have asked to the patient. So do write the questions. Sometimes people say that how often one should be doing the MSc. It depends upon the clinical picture of the patient. So, for example, if the patient is of like it's a forensic psychiatry case, so in that case, every day MSc becomes a rule. If in general 2 to 3 times per week an MSc should be done. However, if for example if the patient is improving, then we can do once a week or twice a week. If the patient is like as I said, of case of forensic psychiatry, one have to do it daily. So it varies according to the clinical picture of the patient. There is no fixed rule that a 48 hours or a 72 hours it describe the clinical picture. As rapidly as the clinical picture change, one should be ideally doing an MSc. But for a safer hand, one can say 2 to 3 times per week is sufficient. Like this should be the frequency of MSc. Do follow what has been given and has been taught in your college, but if in general 2 to 3 times per week is fine, and it depends on the clinical picture of the patient. So with this we come to the end of this video. I hope the video was informative for you. It might have given you a brief overview and the introduction of how to write an MSc, what are the various subheadings to be described, and what are the important definition that one should be knowing. I have also mentioned the source, so it becomes a pretty standardized type of definition. I have also described the various subheadings under each and every disorder of thought and also the disorder of perception. Some do's and don'ts I have also mentioned while so throughout the video. So I hope you all have liked it. Do subscribe to my channel and do follow me on Instagram. The link has been given in the description. Thank you.